Hi, I'm Dr. Wade Alleman. I'm the director of the Kingman Regional Medical Center Imaging Center, as well as the director of Women's Imaging. And I am very delighted to be able to speak with people today and talk about mammography and breast cancer, and specifically breast cancer screening. It's interesting when you evaluate breast cancer and you think about the last 30 years of the significant impact that mammography has had upon the treatment and survivability of breast cancer. Studies show that mammography has decreased breast cancer mortality or breast cancer deaths in the United States by nearly 40% since 1990. They're actually quite staggering numbers and really is a testimony to the impact of mammography and the benefit of following a mammography screening program. Talking a little bit about mammography, it's actually one of the most heavily regulated areas of medicine that there are. There are very strict standards put in place. One for radiation dose, which is some of the smallest that is used in all of medicine. So we strictly keep things very low so that we can keep all these things safe for all of our patients that come through. There are quality standards for all of the equipment that is used. All equipment is tested in some ways daily, in some ways weekly, and in some ways annually for a deeper testing for everything. But everything always meets that standards and even reaches a higher standard of both the government regulations and the ACR regulations as well. In addition, there are education requirements for all those that work in mammography, even specifically for me as the radiologist who's working in it. Of all the different things that I do at the hospital, all the different things I do at the imaging center, my most stringent requirements come in the world of breast cancer care and breast care, and specifically mammography and my mammography training. Let's look a little bit about mammography. So this is a two-dimensional mammographic image. And so what we do is we use very low doses of radiation to pass through the breast. And we take two views of each breast. And what it does is it takes a picture of all the breast tissue kind of compressed together. And then we can look at that tissue and be able to evaluate to see if there are masses there, to see if there are calcifications, which look like little tiny bits of chalk there, or to see if there are changes which can make us worry for breast cancer, which sometimes just means a little bit of pulling together of the tissues, or pulling together or an abnormal pushing away of some of the tissues in the breast. Now, some of the difficult parts that come with a 2D mammogram is the fact you're taking all the breast tissue and you're compressing it together and trying to figure out what's going on amongst all those different breast tissues. One of the greatest advancements that's been made in the last several years is three-dimensional breast tomosynthesis, or 3D imaging or breast tomosynthesis. This was approved by the FDA in April of 2011. And we're very proud at Kingman Regional Medical Center. We were early adopters of this, and we're the first center for 100 miles to be, and one of the first centers in the state to be able to provide 3D mammography. It involves basically taking those mammograms where we compress the breast, but then slicing the breast into 1 millimeter slices and then looking through all those different details that we can see. And rather than having everything superimposed on itself, we can actually look at each individual slice and be able to determine, is that something that's worrisome or is that something that's not worrisome? When breast tomosynthesis first came out, we found several early cancers that we would have never seen beforehand, purely because instead of seeing a compressed breast, we were able to take those thin slices and really evaluate each and every one of those slices and get the best possible evaluation of every mammogram, while still keeping that radiation dose extremely low for each and every one of those women. This is particularly beneficial for women with dense breasts. Talking a little bit about breast density. It's not uncommon for the density of a breast of a woman to change throughout her life. But at the snapshot at the time of a mammogram, we categorize the breast density, or how much breast tissue is in the breast, into 4 different categories. There's a breast that is almost entirely fatty, so almost completely fatty replaced. There's what we call scattered areas of fibroglandular density, which means about 25 to 50% of the breast is breast tissue, while the rest of that is fatty tissue. There's what we call a heterogeneously dense breast, which gets into the category of a little bit more dense. So it's about 50 to 75% density. And then there's the extremely dense breast. So greater than 75% of the breast is dense breast tissue. Most women, when they're young, in their 20s and early 30s, have denser breasts and they become more fatty replaced as time goes on. But everybody is different. And some women will have extremely dense breasts throughout their lives, and some will have fatty replaced breasts from the time they're very young. And all just depends, and it's an important evaluation of every mammogram that we do. So talking a little bit about what happens when you come into your mammogram. Let's picture a group of 100 women that come in and get a screening mammogram. Of those 100 women, 90 of them will be told that their mammogram is normal and that there's no other concerns and they should just come back in a year. 10 of the women will be asked to return from some additional imaging. That might include additional mammographic pictures. In addition to that might include diagnostic ultrasound of the breast as well. Of those 10 that come back, 6 of them will then be able to determine this is still benign or this is still something that's normal and we won't have to worry about it. 2 of them will be asked to come back in 6 months. That's a finding that is probably benign, of very little risk. So we bring them back in 6 months just to make sure nothing has changed. And if nothing has changed at that point in time, then go back to a normal screening mammogram a year later. But 2 of those 100 women will be recommended to undergo a biopsy. And that biopsy will then be able to determine this finding in the mammogram. Is it something that we need to worry about, or is it something that we can let go? Now, one of the most common questions I get as a breast imager and as the director of women's imaging is how often I need to get a mammogram, because there's so much information out there and so much bad information about there. I'm always surprised at who has been told what and what is told to patients and what is told from a sister or a family member about what they should be doing. And then the truth is, medicine itself has made things difficult and government regulation makes things difficult. In fact, that there's many different societies and they've all come up with their different recommendations and their different recommendations of what people should do. So we'll kind of look at a couple of those different groups and what they've said, and hopefully I can boil it down to a couple of very important, very simple points. And if you could go home with nothing else, it's to understand that the recommendation is to start annual screening mammograms at age 40. And then you should get them every single year. So starting at age 40 and have a mammogram every year. In spite of all the things you hear, all the things that are talked about, the science would still point that this is the safest and best way to be able to keep a woman from having advanced states of breast cancer and saving lives. When we look at breast cancer, I'd like to convince you why it's so important to start at age 40 and not wait until you're older. 1 in 6 of all breast cancers occur between the ages of 40 and 49. That is still a very high number and cancers that could be missed if mammography is not performed. When you look at one of the greatest studies that was done, it was done by Harvard. And Harvard evaluated all their patients that they had that had breast cancer and looked at them and found that 20% of the women in their 40s didn't get screened. But 70% of the women that had breast cancer, or who died from breast cancer, were in that small 20% that didn't get screened. It was such a strong illustration of the importance of starting mammography at age 40 and having it done every year. In the end, by not getting annual mammograms starting at age 40, you increase your chances of dying from breast cancer and the likelihood that you will experience more extensive treatment from any cancers that are found. Now, one of the other well-respected societies and their recommendations is that women start no later than 45. The recommendation can still be there to start at 40, but at a minimum, please don't start any later till 45. And they strongly encourage that any woman who wants to start at 40 should have insurance access to those mammograms, which means that they need to be covered by insurance. Now, one of the most confusing recommendations that came out was by a United States Preventive Task Force. And they were tasked with cost-saving measures and figuring out what they thought would be a good recommendation. And they came out with starting at age 50 and screening only every other year. These recommendations have been rejected by many, many societies. Published studies have shown that this would miss about a third of breast cancers. It would result in about 6,500 to 10,000 additional breast cancer deaths per year in the United States. The federal government, so the United States federal government, has actually barred Medicare and private insurance companies from basing mammography coverage, so insurance coverage, upon these guidelines, saying you still have to be able to provide coverage for mammograms based upon what is the best science, which means start at age 40 and every year. And then every reputable scientific organization with expertise in breast cancer care has rejected these findings. So the findings, in spite of what you hear, and sometimes you'll still hear these numbers quite often of, oh, you don't have to start till 50 now, or it's only every other year. The recommendation from every reputable society is start at age 40 and annual screening mammograms. Now, I do hear oftentimes, I don't really need to get a mammogram because I don't have any family history of this. Please remember, 3 out of the 4 women diagnosed with breast cancer have no family history of the disease and are not considered at high risk. Every woman needs to undergo annual screening mammography, irrespective of what the family history is. It does not excuse one from having that without putting them at increased risk. Let's talk about a couple of the other modalities. We talk a lot about screening mammograms, but there are several additional things that we might need to do just to figure out exactly what's going on and to figure out, do we need to worry about some of these findings? One is breast ultrasound, in which we use sound waves to look at the breast and be able to evaluate things. Oftentimes this is used to determine if something is a cyst or if something is solid, or if something has worrisome features or not. And so very common for a woman, if she's called back for additional images, to have an ultrasound also performed at that time. In addition, we oftentimes do breast MRI. Breast MRI does several things for us. One, we use magnetic waves to basically align all of the atoms in the body into one direction. And then we use an energy pulse to be able to make them all quickly move. And then we can measure the energy that comes off that, and we get what's called magnetic resonance images. Of the breast, these are very high quality images that not only give us really good evaluation of the breast, but will also give some dye into the blood system. And we can evaluate whether or not any finding in the breast is taking up that dye or whether it's not taking up that dye. And if it is taking up that dye, how fast is it taking up? Which are all findings that help us determine, is this a high risk of breast cancer, or is this still a low risk and something that we could ignore or just watch? Now, one of the things I'm often asked is about whole breast ultrasound, and this has gotten a lot of play in the media recently. Whole breast ultrasound is becoming more and more popular, and the truth be told, there is a minimal increase in the detection of breast cancers when doing whole breast ultrasound. However, there is a significant, very large increase in the false positive findings, which that usually is interpreted as is lots and lots of women are having many, many more biopsies, but those biopsies are all coming back as negative. They're things that we didn't need to worry about if we hadn't gone looking with the ultrasound. What happens is that ultrasound finds all kinds of things, but there's some very subtle things that can make people worried, and as a result, we can become overly concerned about things that really don't matter. At this point in time, the quality of those whole breast ultrasound images, as an institution, we've determined are not quite good enough and doesn't increase cancer detection enough to warrant all those biopsies that come back negative and those false positive findings. However, my expectation is here in the very near future, the quality of those images will become sufficiently good, and the quality of the interpretation will become sufficiently good that we can take that and use that as an additive measure in screening for breast cancer for patients. Now, we talked about family histories of breast cancer and what the average woman would need to undergo, which is starting at age 40 and having an annual screening mammogram. But the truth is some women are just at a very, very high risk of breast cancer because of their family history. We have several calculations that we can perform that can determine a woman's breast cancer risks. And anybody who is considered to have a breast cancer with higher than 20% or 20% risk of developing breast cancer in a lifetime is categorized as a very high family history or a very high risk person with regards to getting breast cancer. Typically, these numbers are based upon your first-degree relatives, meaning usually your mother or your sister. Although there's a small increase in risk when patients have grandmothers and aunts that have had breast cancer, in the end, the most important ones that we look at: did your mother have breast cancer? Do you have a sister that had breast cancer? And at what age was that breast cancer diagnosis made? In addition, there are women that have known genetic mutations, sometimes called the BRCA1, BRCA2, or the BRCA1 and BRCA2 genetic mutations. These women are all at a very, very high risk, and so we have to adjust our screening protocols. The science of exactly what to do isn't quite as good, but our only goal that we have is what do we need to do to make sure we can keep these women safe, to make sure that they are cared for, and to make sure that their families and their daughters and their sisters are also cared for. So in women that have either a known genetic mutation or a breast cancer lifetime risk greater than 20%, the recommendation is to start screening mammography annually at age 30. In addition, the breast MRI, we recommend starting annually at age 25 to 30, and that can be a discussion you have with your primary care provider, and having annual screening breast MRI done as well. So women that are at very high risk, either having a greater than 20% risk of breast cancer or a known genetic mutation, start their screening mammograms at age 30 and likely start actually screening with breast MRI at 25 to 30. It used to be the teaching was that you could never replace mammography, that even if you got an MRI, you still had to get mammography. Now that is not the case, and it's worth having a discussion with your physician about what the best way to handle it is. And a lot of times we can either go 1 year with MRI or 1 year with mammograms, or another variable depending upon what we need to do for you. In addition, women that have had breast cancer at any age that have dense breasts, or women that have breast cancer less than 50, so they're in the same situation in which we recommend them having an annual screening breast MRI starting at the time of their diagnosis of breast cancer. And one of the other common questions is, when can I stop getting a mammogram? Right now, the science and all the research that was done in mammography studied women for screening for breast cancer until the age of 77. And so the decision to continue screening after age 77 should be made between the patient and her primary care physician. With increasing life expectancy of so many patients, it may be wise for you to continue screening at a much greater age. However, this is an important discussion, and you should have it with your physician to determine at what age you should stop screening for breast cancer. I hope this has been able to answer several of your questions with regards to what exactly does a mammogram do? What is the likelihood I'm going to get called back, and should I be nervous if I am? How often should I have a screening mammogram? And if I have an increased family risk, does that change the recommendations? Again, if there are any questions that should ever come up, we always have physicians that are able to talk to you at the Women's Imaging Center or the KRMC Imaging Center, and just contact us. We'd be happy to discuss things with you. In addition, when you come in for your screening mammogram, if questions should arise, we're always happy to be able to talk with you and discuss those questions. Thank you so much for your time.